Good evening, Dr. Phil here. Today we'll be discussing on organophosphate poisoning. Organophosphates are used in pesticides, insecticides, herbicides, and chemical warfare agents. OP used in insecticides are usually ester, amide or thiol derivatives of phosphoric acid or phosphonic acid or their mixtures. Examples include diisopropylfluorophosphonate DFP, tetraethyl pyrophosphate TEPP, parathion, chloroserine, cycloserine, R33, RVX, serine, tabun, VX, chlorosoman, and soman. Exposure to organophosphates may cause more deaths worldwide each year compared to other xenobiotics. Mortality rate in OP poisoning is 10 to 40%. OP poisoning in humans are not uncommon among farmers due to chronic occupational exposure. Chronic exposure may produce polyneuritis. OP poisoning can also occur during accidental poisoning, in suicide attempts, homicidal attempts, and during war. Pathophysiology. Organophosphates inactivate acetylcholine esterases by phosphorylation of the serine hydroxyl moiety at each of the 6 active sites of ACHE irreversibly. A very stable complex resistant to reactivation or hydrolysis is produced. Long-lasting increase of acetylcholine results in increased cholinergic activity at all sites where it is released, resulting in nicotinic effects, muscarinic effects, CNS effects. Muscle weakness may take up to 3 weeks to recover. Kindly refer to the video on cholinergic agonists for further details. Recovery and restoration of acetylcholine esterase activity requires the synthesis of new acetylcholine esterase. Other enzymes are phosphorylated as well, including lipases and GI enzymes. Delayed polyneuropathy develops 2 to 4 weeks after the cholinergic crisis, presenting with weakness, paresthesia, and pyramidal signs. Recovery is variable. Absorption of organophosphate occurs via the lungs, GI tract, and the skin. It distributes to all tissues rapidly, especially the liver and the kidneys. Half-life varies from minutes to hours. Metabolism occurs via oxidation, ester hydrolysis, and combining with glutathione. Excretion of organophosphates is in the urine and feces. There are limited benefits of organophosphates in humans. Clinical trials are in progress for development of new organophosphorus compounds in treating Alzheimer's disease. Ecothiophate is an organophosphorus compound with a quaternary amine group. It inactivates acetylcholine esterase permanently by covalently binding via its phosphate group at the active site of ACHE. Therapeutic uses of ecothiophate includes topically causing intense meiosis, and it is used to treat open-angle glaucoma. However, it is rarely used due to its side effect profile. There is risk of causing cataracts. Ecothiophate has been withdrawn from the UK market. Clinical features. Overdose of anticholinesterases results in effects induced by excessive acetylcholine. It can result in muscarinic effects, nicotinic effects, and CNS effects. Muscarinic effects includes increase in exocrine gland activity, resulting in sweating, lacrimation, salivation, rhinorrhea, bronchorrhea, and hyperamylasemia. Cardiac effects includes bradycardia, hypotension, arrhythmias such as AV block, ventricular dysarrhythmias, idioventricular rhythm, etc. There is increased smooth muscle activity, resulting in bronchoconstriction, increased GI motility, resulting in vomiting, abdominal cramps, and diarrhea, bladder stimulation, incontinence and urination, sphincter relaxation, meiosis resulting in blurred vision. Nicotinic effects includes muscle fasciculation, weakness and cramping. CNS effects includes agitation, confusion, lethargy, tremors, ataxia, seizures, status epilepticus, loss of consciousness. Central effects may occur if the drug crosses the blood-brain barrier. It is apparent during overdose or poisoning. Respiratory failure occurs due to bronchoria, respiratory muscle weakness, and hypoventilation of brainstem origin. Shock occurs due to hypovolemia, secondary to GI losses and exocrine gland hypersecretion, and cardiogenic shock from bradycardia, hypotension, arrhythmias, and heart failure from respiratory failure-induced hypoxemia and hypercarbia. A useful mnemonic is sludge jam, which stands for salivation, lacrimation, urination, diarrhea, GI upset, emesis, and meiosis. To differentiate myasthenic crisis from cholinergic crisis, administer IV adrophonium 2 mg, which improves symptoms of myasthenic crisis and worsen or has no effect on symptoms of cholinergic crisis. Management of organophosphate poisoning. General measures to undertake when the patient presents with suspected poisoning. Resuscitation as per ATLS protocol. ABC, clear airway. Consider mechanical ventilation if respiratory rate is less than 8, PaO2 is less than 60 mmHg when breathing 60% oxygen, and when the airway is at risk, such as GCS less than 8. Treat shock. Diagnosis. From the history, from the patient, or friends and family, take note that the patient may not tell the truth. Physical examination. Investigations includes glucose, urea electrolytes, full blood count, liver function test, coagulation profile, arterial blood gases, ECG, urine and serum toxicology, and specific assays as appropriate, such as acetylcholine assay, measurement of blood and urine organophosphorus and metabolite levels. Always check paracetamol and salicylate levels as well. Assess response to atropine therapy. Psychiatric assessment and referral may be indicated if the patient is stable. Monitor regularly temperature, pulse, respiratory rate, blood pressure, oxygen saturations, blood glucose, urine output and ECG. Nurse semi-prone if unconscious. Catheterize the bladder if the bladder is distended, suspected acute kidney injury, and if forced diuresis is employed. If you are not familiar with the poison, get more information, for example from tox-base. Hemodialysis may be required for poisoning from organophosphates, ethylene glycol, lithium, methanol, phenobarbital, salicylates, sodium valproate, oxalic acid, or formic acid. Proceed with specific measures and antidotes. Refer for ICU care as appropriate. Further details for measures for poisoning and overdoses will be discussed in a future video. Decontamination. Activated charcoal is effective only if given within the first hour of OP ingestion. Activated charcoal is the treatment of choice for GI decontamination rather than GI lavage. The dose is 50 grams with water or 50 grams 4 hourly. It is effective against carbamazepine, dapsone, thiophyllenes, quinine, phenobarbital, paraquat, and organophosphates. Activated charcoal is not effective against petroleum products, corrosives, alcohols, chlorphenotane, malathion, and metal salts such as iron and lithium. GI lavage may be considered prior to activated charcoal administration in intubated patients. GI lavage is not effective against petroleum products and corrosives such as acids, alkalis, bleach, descalers, except paraquat. Decontamination of the skin. Removal of attire and washing exposed patients reduces further OP absorption and prevents transmission of OP to healthcare workers and should be done ASAP and prior to admission to ICU. Wear full personal protective equipment during skin decontamination. Anticholinergic drugs. Atropine. This is the first-line treatment in organophosphate poisoning. Atropine is the ester of tropic acid and tropine found in deadly nightshade. It is a tertiary amine belladonna alkaloid. It is a competitive antagonist at muscarinic acetylcholine receptors. It does not block nicotinic receptors, thus has no action at neuromuscular junctions. Muscle weakness still occurs. Atropine does not block autonomic ganglia as well. Atropine does cross the blood-brain barrier and blocks OP-induced CNS effects. Onset of action is 30 seconds via IV. Duration of action is 4 hours for IV, IM, and orally. If applied topically to the eye, it can last for days. Pharmacokinetics. It is readily absorbed via various routes such as IV, intraosseous, endotracheal, IM, and subcute. Atropine is partially metabolized by the liver, eliminated by the kidneys. Half-life is 4 hours. Effects of atropine. CVS effects. Tachycardia at high doses via blockade of the M2 receptors on the sinoatrial node. At low doses, atropine can cause bradycardia via blockade of the M1 receptors on the inhibitory prejunctional or presynaptic neurons, which permits increased acetylcholine release. Bradycardia can also occur due to central vagal stimulation. Cutaneous vasodilation occurs. CNS effects of atropine includes excitement, hallucination, delirium, CNS depression, cardiorespiratory collapse, and death in atropine overdose. Hyperthermia, especially in children. Avoid atropine in pyraxial patients. Atropine has anti-Parkinsonian effects. Atropine causes bronchodilation and reduced respiratory secretions. Effects of atropine on GI tract includes decreased secretions, decreased salivation, and decreased motility. Atropine acts as an antispasmodic. There is decreased lower esophageal sphincter tone. Other effects include decreased sweating. Atropine can cause elevated body temperature. Mydriasis. Atropine can provoke closed-angle glaucoma in susceptible patients as the iris obstructs drainage of aqueous humor. Cycloplegia. Decreased lacrimation, decreased bladder and ureteric tone, resulting in urinary retention. The atropine dose in OP poisoning via IV or IM route in children 0.05 mg per kg every 10 to 20 minutes until atropine effect is seen, and then every 1 to 4 hours for at least 24 hours. The adult dose is 2 mg IV or IM. If severe symptoms develop, 2 additional doses can be given until atropinized, each 10 minutes apart, up to a total of 6 mg. If severe symptoms present initially, sequential 2 mg times 3 can be given in quick succession. Once atropinized, start IVI atropine at 0.02 to 0.08 mg per kg per hour. IVI may be needed for several days. Dosages for other indications of atropine. Pre-medication as an anti-secretory, IM 0.3 to 0.6 mg in adults, or 0.01 to 0.02 mg per kg for children. In bradycardia treatment, IV 0.5 mg up to 3 mg total for adults, or IV 0.02 mg per kg for children. As an antimuscarinic during non-depolarizing neuromuscular blockade reversal by anticholinesterases, the dose is IV 0.01 to 0.02 mg per kg. As an antispasmodic, it is oral 0.6 to 1.2 mg on night. As a mydriatic, it is administered as eye drops. Glycopyrronium. This is a competitive antagonist at muscarinic acetylcholine receptors. Compared with atropine, glycopyrronium does not block the OP-induced CNS effects, as it is a quaternary ammonium compound and does not cross the blood-brain barrier. Thus, glycopyrronium has minimal central effects, unlike atropine or hyoscine. Glycopyrronium is less likely to cause tachycardia, mydriasis, and blurred vision. It more markedly reduces production of sweat and saliva. The action of glycopyrronium persists longer than that of atropine, 4 hours versus 7 hours. It reduces post-operative bradycardia, and dry mouth may persist post-operatively if administered. Glycopyrronium does not block nicotinic receptors. Muscle weakness still occurs. Glycopyrronium is used with atropine in OP poisoning when atropine causes antimuscarinic CNS toxicity, i.e. central anticholinergic syndrome. This has been discussed in the video on cholinergic agonists. Glycopyrronium is also used with atropine when atropine does not completely reverse peripheral muscarinic effects. Onset of action is 1 minute if given IV and 10 to 15 minutes if given IM. Duration of action of glycopyrronium: vagal block 2 to 3 hours, anti-Psylocke up to 7 hours. Half-life is 0.6 to 1.2 hours, Metabolism unknown. Excretion 80% urine, the rest in the bowel. More than 80% excreted unchanged. Dose of glycopyrronium for OP poisoning, IV 1 to 2 mg repeated as needed until symptoms resolve. For other uses, pre-medication, treating and preventing bradycardia, 4 to 5 micrograms per kg IM or IV, as an antimuscarinic during non-depolarizing neuromuscular blockade reversal by anticholinesterases, IV 10 to 15 micrograms per kg. Glycopyrronium is also used in COPD treatment. Chemical reactivators includes pralidoxime and obidoxime. Pralidoxime reactivates acetylcholinesterase by binding directly to the organophosphate molecule. The charged group of pralidoxime allows it to approach an anionic site of acetylcholinesterase. It then displaces the phosphate group on the organophosphate and regenerates the enzyme. Conditions where pralidoxime is ineffective. Chemical reactivation of acetylcholinesterase is not possible if aging of the acetylcholinesterase OP complex has occurred. Pralidoxime is ineffective once the OP has bound irreversibly to acetylcholinesterase. It must be thus administered within 48 hours of OP poisoning. Following covalent modification of acetylcholinesterase by organophosphate, acetylcholinesterase undergoes a process called aging, where there is a loss of an alkyl group. If aging has occurred, it is impossible for the chemical reactivators to break the bond between the remaining drug and the enzyme. Pralidoxime can't penetrate into the CNS. It is only able to reverse both muscarinic and nicotinic peripheral effects, but it is not useful in treating the CNS effects of OP poisoning. Pralidoxime is less effective against newer nerve agents that can produce aging of the ACHE OP complex within seconds. Pralidoxime cannot overcome the toxicity of reversible acetylcholinesterase inhibitors such as physostigmine. The dose of pralidoxime, in children it is 50 mg per kg over 30 minutes up to 2 grams, then 20 mg per kg per hour for 48 hours up to 1 gram per hour, and then 20 mg per kg up to 1 gram every 4 hourly. In adults it is 2 grams over 30 minutes, then 1 gram per hour, then 1 gram over 1 hour every 4 hours. Administered until reversal of cholinergic symptoms occur, treatment might require several days. Obidoxime is a bis-pyridinium reactivator used as an antidote for organophosphorus poisoning. Obidoxime is also an allosteric modulator of muscarinic receptors, preferably affecting the M2 subtype. The efficacy of obidoxime as a cholinesterase reactivator is nerve agent specific and is effective against OP poisoning caused by paroxysone and tabun. Obidoxime failed to demonstrate a strong therapeutic efficacy against OP pesticide poisoning in prospective clinical studies compared to pralidoxime. Benzodiazepines. Benzodiazepines are used for OP-induced agitation and seizures. Benzodiazepines are also used to treat anxiety disorders, insomnia, amnesia, and muscle spasms. Mechanism of action. Benzodiazepines potentiates increased chloride ion conductance caused by endogenous GABA by binding to alpha and gamma subunits of the GABA-A receptor complex. The GABA-A receptor consists of 5 subunits, 2 alpha, 2 beta, and 1 gamma, that span the postsynaptic membrane. Many subtypes exist for each subunit. For example, the alpha subunit has 6 subtypes. Opening of the central ion channel occurs when GABA binds to its receptor, resulting in chloride influx into the cell and hyperpolarization of the neuron. Neurotransmission is reduced as formation of action potentials are inhibited. Benzodiazepines increases the frequency of ion channel openings produced by GABA. Thus, they enhance GABA-mediated inhibition in the brain and spinal cord, particularly in the limbic system and ascending reticular activating system. Actions of benzodiazepines. Sedation and hypnosis, antegrade amnesia, and anticonvulsant effects are mediated by the alpha-1 GABA-A receptors. Muscle relaxation at the spinal cord and anxiolysis at the limbic system. are mediated by the alpha-2 GABA-A receptors. Advantages of benzodiazepines. They cause antegrade amnesia, they have anticonvulsant effects, they are the sedative of choice for drug withdrawal syndromes due to alcohol, opiates, and benzodiazepines. Flumazenil is the specific antagonist in case of overdose. Benzodiazepines are safer and more effective than barbiturates. Disadvantages of benzodiazepines. They have the propensity for drug accumulation and prolonged sedation. Daily interruption of benzodiazepine infusions and titration of drug dose to maintain light levels of sedation reduces the time for awakening when the drug is discontinued. Being GABA agonist, benzodiazepines increases delirium by enhancing GABA-mediated neurotransmission. Propylene glycol toxicity can occur with lorazepam. Propylene glycol is a solvent used to increase the solubility of lorazepam in the plasma. Propylene glycol is converted to lactic acid in the liver. Features of propylene glycol toxicity includes delirium, hallucinations, hypotension, multi-organ failure, lactic acidosis, and elevated osmolar gap. Benzodiazepine withdrawal syndrome can present with agitation, disorientation, hallucination, and seizures. Other effects of benzodiazepines includes drowsiness, confusion, ataxia, cognitive impairment, tolerance. CNS depression worsen if other CNS depressants are taken concurrently. Absorption and distribution. Being lipophilic, benzodiazepines are rapidly and completely absorbed if administered orally and distributes throughout the body, including the CNS. They cross the placenta and is secreted in breast milk. Metabolism. Most benzodiazepines are metabolized by hepatic microsomal systems to compounds that are often active. Termination of drug effects is via excretion and redistribution. Elimination. Benzodiazepines are excreted in the urine as glucuronides or oxidized metabolites. Benzodiazepines used in OP poisoning. Diazepam, midazolam, and lorazepam. Diazepam. Uses. As a sedative, anticonvulsant, and anxiolytic, dose is IV 2 to 10 mg or 0.04 to 0.2 mg per kg, 8 to 12 hourly. Per rectal dose is 0.3 to 0.5 mg per kg, maximum 20 mg. For pre-medication, oral 10 to 30 mg or 0.2 to 0.4 mg per kg in children up to 10 mg orally. PR dose 2 to 3 mg diazepam equals to 1 mg midazolam. For skeletal muscle spasm including tetanus, slow IV or IM 5 to 10 mg repeated if necessary, 1 to 4 hourly. Or IVI 3 to 10 mg per kg body weight per 24 hours. Delirium tremens 10 to 20 mg IV or IM. Diazepam is also used to supplement or induce anesthesia. Diazepam is insoluble in water. Emulsions of diazepam in soybean oil rarely cause pain on injection, unlike earlier formulations. Some adverse effects of diazepam include respiratory depression, reduced cardiac output and vasodilation in large doses, drowsiness, confusion. IM injection is painful and absorption is not reliable. Half-life of diazepam 20 to 70 hours. Active metabolites of diazepam, nordiazepam, which half-life is up to 120 hours, desmethyldiazepam, oxazepam, temazepam. Repeated doses of diazepam leads to delayed recovery due to these active metabolites. Midazolam. Uses. As a sedative, loading dose is IV 0.01 to 0.05 mg per kg increments. Continuous infusion, IVI 0.02 to 0.1 mg per kg per hour. Intermittent bolus dosing can be given. Midazolam is used as an anxiolytic and anticonvulsant as well. For pre-medication, IM 0.07 to 0.1 mg per kg or oral 0.5 to 0.75 mg per kg. Induction of anesthesia up to 0.3 mg per kg. Midazolam has an imidazole ring. It is a 5-member ring containing carbon and nitrogen atoms. Structural isomerism occurs. The ring opens when pH is less than 4, making midazolam water-soluble. The ring closes at body pH, making midazolam highly lipid-soluble, resulting in rapid onset of action. Thus, midazolam has high lipophilicity in the body. Onset of action is 1 to 5 minutes. The fast onset is due to high lipid solubility. Duration of effect is 1 to 2 hours. Brief duration of effect due to avid drug uptake into tissues rather than drug elimination. Continuous infusion results in drug accumulation in tissues. Thus, midazolam infusions should be less than 48 hours to avoid prolonged sedation. Elimination half-life is 1.5 to 2.5 hours. Metabolism of midazolam is hepatic. After metabolism of midazolam by cytochrome P450 enzyme system, the active metabolite alpha-1 hydroxymidazolam has 10% of the activity of midazolam, and this prolongs sedation, especially in cases of renal failure, as it is cleared by the kidneys. Excretion of midazolam is renal. Adverse effects of midazolam includes respiratory and cardiovascular depression. Lorazepam. Uses include sedative, anticonvulsant, hypnotic, and pre-medication. As a sedative, lorazepam produces more amnesia than other benzodiazepines. Loading dose is 0.02 to 0.04 mg per kg, maximum 2 mg. Continuous infusion 0.01 to 0.1 mg per kg per hour, maximum 10 mg per hour. Intermittent bolus dosing 0.02 to 0.06 mg per kg, 2 to 6 hourly. Anticonvulsant. Lorazepam is the drug of choice for status epilepticus. Dose is IV 25 to 30 micrograms per kg for seizures and IV 50 to 100 micrograms per kg for status epilepticus. Lorazepam can be used as a hypnotic to treat insomnia and as a pre-medication with a dose of IV 1 to 4 milligrams. Onset of action is 5 to 20 minutes, duration of effect is 2 to 6 hours, half-life is 12 hours. Lorazepam has high lipophilicity, thus can accumulate in tissues and prolong sedation. There are no active metabolites for lorazepam. Specific concerns includes propylene glycol toxicity discussed above. Preventive agents. Pyridostigmine has been used prophylactically in people threatened by chemical warfare with organophosphorus compounds. These are my references. Thank you.